Thank you for having me. My name is Stephen Horwitz, and I'm a member and attending physician at Memorial Sloan Kettering Cancer Center. And today I'll be discussing the management of frontline peripheral T-cell lymphoma, and it's a pleasure to join you all remotely. These are my disclosures. So I think when we think about peripheral T-cell lymphoma, I think back to a story which I may have told before, where Randy Gascoigne, who's a pathologist in Vancouver, was asked to review T-cell lymphomas for the ECOG lymphoma group. This is back when Sandra Horning was the chair. And as the story goes, Randy stood up and said T-cell lymphomas are heterogeneous and BAD, or bad, or poor prognosis. And I think while we're trying to change that, we do know that historically the T-cell lymphomas have been daunting for clinicians, oncologists, hematologists, mostly due to the poor prognosis and the higher rates of chemo-refractory disease when compared to their B-cell counterparts. But more and more, as we understand about the different subtypes of T-cell lymphoma, the heterogeneity really becomes an issue. There are almost 30 different subtypes in the latest iteration of the WHO. And as I hope to show you that some of the progress is being made in a subtype or target specific fashion, that really then puts an onus on the oncologist to sort of understand some of these subtypes in a more specific or nuanced way. And this just shows on the left a series of a deep dive in genomics by a group in Japan, looking at peripheral T-cell lymphoma and sort of trying to recapitulate some of what's been done in diffuse large B-cell lymphoma with different types of molecular genetic subtypes, something probably beyond ABC. And I think right now, if you look on the left, you see that's very complicated, but we do see that different groups of T-cell lymphomas are enriched for signaling pathways like JAK-STAT or PI3 kinase AKT. Certain things like follicular helper T-cell lymphoma are enriched for mutations in epigenetic regulators. There's a group that may have defects in TP53. And while these don't really rise to the level of classification right now, as the biology is being understood, some of that is just starting to translate into clinical decisions. There's a nice figure on the right from Javeed Iqbal's group, which I really like, because I think in a fairly simple way, it takes peripheral T-cell lymphomas or systemic T-cell lymphomas and groups them into different groups where we may have some therapeutic insight. And those include things like with PI3 kinase and AKT signaling, where there are inhibitors of that pathway. There's groups that are very enriched for epigenetic changes, and data suggests that those patients may benefit more from targeting epigenetics, whether that's histone or acetylation or methylation. And then there's other groups that may have greater perturbations in signaling, and maybe going after that group will bear fruit in terms of finding better therapies. But right now, most of this is sort of understanding the biology more than directly actionable clinical information. One simple way I think about it, sort of like as a clinical framework in thinking about patients with aggressive T-cell lymphoma, is we think about CHOP as that one-size-fits-all approach that we've tried to move away from. But if we think about CHOP as that one-size-fits-all approach, are there a group of diseases where building on that strategy may do better? And are there groups where we think that's not a winning strategy? And I think you can kind of break this down and think about sort of that middle group in the blue, where I wrote here, CHOP-based therapies are reasonable. And these are most of the systemic T-cell lymphomas where combination chemotherapy, or what is very often intensification of that chemotherapy, does cure some patients. There's a group on the left where patients either maybe have very indolent disease, like cutaneous T-cell lymphomas, where CHOP is not successful and needlessly aggressive, or other very aggressive disease where combination chemotherapy like CHOP never cures anyone. And then there's a group I listed on the right, which we think we have some ideas about how to treat, but the data is so limited that it's really hard to make a strategy. So I think my conclusions, of this introduction is, a one-size-fits-all approach is really illogical as we're understanding more about these different diseases, and it's too often ineffective. And we really need new approaches, new therapies, new strategies, and that's mostly what I'll be focusing on. So where is CHOP reasonable? Are there ways to improve upon it? And I would say, as you all well know, most of the modifications to CHOP have been in terms of dose intensification. So I'll gloss over a lot of data and just kind of hit a few highlights in terms of maximal chemotherapy or dose intensification. One of the most commonly used modifications is the addition of etoposide. So this is data from prospective studies done in Germany, adding etoposide to a CHOP backbone for patients with aggressive lymphomas in general. About 10% of the patients had T-cell lymphomas, and this is the subset analysis. The caveat that'll come back later is if you look here on the bottom left, you see that while this was for patients with peripheral or mature T-cell lymphomas, almost 2/3 or 60% or so of the subjects had anaplastic large cell lymphoma, and the other subtypes were less often represented. And this comes into, becomes important when we're looking at the echelon-2 data, where that data set has similar biases. Patients over age 60 had excess toxicity. So if you confine the analysis to those with age less than 60, you see this statistical benefit in terms of event-free survival. Most of the numerical benefit was in patients with the already more favorable ALK-positive ALCL, where it looked like the addition of etoposide really added. And when we look at just the other subtypes, we see this trend for benefit in terms of event-free survival, and there was no benefit in overall survival. And we do know, again, as I mentioned, that etoposide adds toxicity. So in younger patients, aged 18 to 60 in the top, you see that there was statistically more frequent leukopenia, thrombocytopenia, infection, but at least in the younger group, that didn't translate into significant more infections. Where if you look at the bottom curve in the patients 61 to 75, you have that same statistical increase in myelosuppression, but here it does translate into clinical consequences with much higher rates of infection and much higher rates of mucositis. And that really, excess toxicity overrode or limited the ability to detect any benefit of giving more potent chemotherapy. When we take combination chemotherapy sort of to its extreme, we know we can maximize doses in the setting of high dose therapy on autologous stem cell transplant. And there is phase 2 data to suggest that that may help a proportion or a subset of patients with T-cell lymphoma. So this is prospective data from the Nordic group where patients were induced with CHOP etoposide given every 2 weeks. So more dose intense and more dose dense. Patients over 60 got CHOP, and those patients who responded partly or completely went on to consolidation with high dose therapy and autologous stem cell transplant. And by an intent to treat analysis, so this includes the transplanted and the non-transplanted patients, the 5-year overall survival was just over 50%, the 5-year PFS was 44%, and we think this compares favorably to historical controls where those numbers would more be in the 20 to 30% range. If you look, for instance, on the bottom right, by progression-free survival by subtype, you can see that the benefits or the prognosis is not equal across all subtypes. And the gray bar were patients with ALK-negative anaplastic large cell lymphoma, and they seem to fare the best with this dose-intensified approach, and lower rates of PFS for those with peripheral T-cell lymphoma, unspecified or enteropathy-associated T-cell lymphoma. So adding to a CHOP backbone, there's been a couple of studies in the past that have added looking at things like alemtuzumab or other chemotherapies, which I won't go into, but sort of the most recent data that really shows a step forward has been, of course, the echelon-2 data. So again, as many of you know, echelon-2 looked at adding brentuximab vedotin to combination chemotherapy for patients with Cd30 expressing T-cell lymphoma. I think the key eligibility criteria that I want to focus on is patients could have anaplastic large cell lymphoma of any type. If you had ALK-positive disease, which we know is more favorable, you were eligible if your IPI was 2 or greater, and any patient with ALK-negative ALCL was eligible. If you had one of the other subtypes of systemic T-cell lymphoma, you had to have Cd30 expression of greater than or equal to 10% on your tumor cells, and that was by local pathology review. Importantly, the study was powered to be able to look overall by intent to treat, as well as in the anaplastic large cell lymphoma subset by itself. So the study was powered to have about 75% of patients having ALCL. And importantly, the other subtypes are underpowered to make independent conclusions. The treatment regimen was standard dose brentuximab vedotin with cyclophosphamide, doxorubicin, and prednisone as given in standard CHOP with placebo vincristine, or standard CHOP with placebo brentuximab vedotin. And this was a randomized double-blinded study. Primary endpoint was progression-free survival by blinded independent central review. These are the baseline characteristics. As I pointed out, about 70% of patients in the study had systemic anaplastic large cell lymphoma, lower numbers with other types of T-cell lymphoma. And again, you'll note that those numbers are not balanced between arms. As is typical for patients with T-cell lymphoma, the majority of patients had intermediate or high IPI disease, and most patients had advanced stage disease. The median age was just under 60 at age 58. And I think that's important when we look at other data sets, that this is a little lower, probably reflecting the enrichment for anaplastic large cell lymphoma, as well as a clinical trial population. And this is the outcome by primary endpoint. So there was a statistical improvement in progression-free survival, with more than doubling the median PFS with brentuximab vedotin CHP compared to CHOP. And that translated into an overall survival benefit, again, with a statistical improvement in overall survival for patients getting BV-CHP compared to those with CHOP. I'd also point out here that if you look at the CHOP arm, this is also better than historical controls. So this is not a situation where it appears that the standard arm did poorly. It looks like truly the investigational arm did better. This is 5-year data that we updated last year, again, showing persistent benefit in both progression-free and overall survival for brentuximab vedotin and CHP over CHOP. And there I point out there. In terms of adverse events, they were really quite similar between the two groups. The toxicities in the blue or teal bar are BV-CHP, in the purple bars are CHOP, and the darker colors are grade 3 to 4, the lighter colors are grade 1 to 2. And if you just do a high level look, there's really not significant differences in the size of the bars or the shading, really with the exception of diarrhea, which was more frequent both in terms of a rate and grade in patients with BV-CHP. But if you look here at neutropenia or you look here at peripheral sensory neuropathy, they're relatively similar between the two arms. Importantly, as we think about using this, is that primary prophylaxis was allowed on study at investigator discretion, and it significantly reduced the dose of reduced the risk of grade 3 to 4 neutropenia and reduced the risk of febrile neutropenia. So at least in the US, per FDA label, G-CSF for primary prophylaxis when giving BV-CHP is recommended. When we look at peripheral neuropathy, and this would be one of the questions because we're adding a drug, brentuximab vedotin, whose main or most frequent side effect is peripheral neuropathy, we see that the number of events for treatment-emergent peripheral neuropathy are similar. You can see that both graphically here or in the table on the right, though there was a little less resolution of peripheral neuropathy in BV-CHP. So more patients on the CHOP arm at last follow-up had resolution or reduction of their neuropathy to grade 1. And that was a little different than the BV-CHP arm, though you'll see here that most of the incidences of ongoing neuropathy were grade 1. In terms of other secondary efficacy endpoints, the CR rate was higher for BV-CHP, 68%. For CHOP, the CR rate was 56%. Overall response rate was similar. And again, here's the data for systemic anaplastic large cell lymphoma, and that stands alone with statistical benefit in terms of progression-free survival. When we look at CD30 expression, it's been hard to tease out. So we know in ALCL, almost all the patients have high CD30 expression. So this was a look at CD30 expression in response to BV-CHP for patients in the study with PTCL-NOS or angioimmunoblastic T-cell lymphoma. And you can spend some time looking at this. I think the bottom line is the majority of patients had relatively low rates of CD30 expression, sort of between 10, which was required for inclusion, and 20%, though there are occasional patients with higher percentages of CD30 expression, but there was no real clear difference in terms of response or complete response as to whether you were a high CD30 expressor or a low CD30 expressor. So we would say when we're looking at this data, CD30 expression applies to this data set because that was required for entry. Again, in the study, it was 10% by local review, but it's not really possible outside of ALCL to stratify likelihood of response or degree of response based on CD30 expression. High dose therapy and auto transplant, as I mentioned, which is a fairly standard addition to combination chemotherapy for patients with T-cell lymphoma, was allowed per study. So per investigator, you could consolidate a remission with high-dose therapy and auto stem cell transplant, and that was not considered an event. If you did it to try to make up for inadequate response or to treat relapse disease, it was considered an event. And there was a subset analysis or retrospective analysis looking at the use of transplant. So here you just see the numbers of patients who got transplant for ALK-negative anaplastic large cell lymphoma or non-anaplastic peripheral T-cell lymphoma. These are patients who had a complete response at the end of treatment. You'll see that the numbers are relatively small in the study. The most patients did not get transplant in either group. The age is a little younger for those who got transplant than for those who didn't get transplant. And here are the prognostic scores for those two different groups. When we look at the curves from that, what you can see is that PFS by transplant or no transplant does look to be improved in the patients who got consolidated transplant. Again, these are only the patients who had a complete response, and that holds whether you look at all patients. And again, it looks like there may still be some incremental benefit in patients with anaplastic large cell lymphoma, as well as patients with angioimmunoblastic T-cell lymphoma or peripheral T-cell lymphoma unspecified. So again, this is a retrospective look. These patients were not stratified, they were not randomized, so you sort of have to take this with a grain of salt. But as someone who has a bias towards transplant, to me, this sort of reinforces that there may be some additional benefit by adding transplant at the end of chemotherapy for those with chemosensitive disease. I think if you were skeptical because of all those reasons in this retrospective analysis, I'm not sure it would totally change your mind, but that's the data that we have. So I think when we think about adding to a CHOP backbone, adding a BV to a CHOP backbone in untreated peripheral T-cell lymphoma, the way I look at it is for anaplastic large cell lymphoma, there's an overall survival benefit for the whole group that statistically holds for those with ALCL. So at least for us now, this is the standard of care. I think when we look at CD30 expressing other types of T-cell lymphoma, PTCL, NOS, and angioimmunoblastic T-cell lymphoma, well, for us, they're part of the intent to treat population and they're on label in the US. As I mentioned, the subset size precludes statistical conclusions, so I think we're left with sort of very imperfect data in terms of how we choose for our patients. So we have two data sets, BVCHP and CHOEP, and I showed you the data for CHOP plus etoposide. That might be better than CHOP alone, albeit the improvement may be small and the statistical conclusiveness in those cases is lacking. So those are imperfect data sets. As someone myself who is not very satisfied with CHOP and sort of has a desire to do better, I think either of these are okay to do instead of CHOP, with the caveat that we don't really know for sure, at least based on randomized studies, that we're truly improving the results for our patients. BVCHP didn't add a lot to toxicity, a little more diarrhea. CHOP etoposide, particularly in older patients, did add more significant hematologic toxicity. With regard to consolidation with auto transplant, at least to my eyes, it appears that there still is room for incremental benefit, even if we get patients into remission with BVCHP, and our standard is that we still add it. I didn't really get into or show you data on DUS22 or TP63, which may be other genetic prognostic markers in anaplastic large cell lymphoma. But right now, those analyses are sort of underway, and I'm not sure that the Echelon-2 study is going to give us additional information as to whether we should treat those patients differently. But adding an active drug to CHOP and enriching for those most likely to benefit, in this case, CD30 expression, does seem to be a strategy that's improved progression-free and overall survival. And again, the median overall survival of CHOP in this arm is not met at 5 years. So when we think about standard approaches, there is a rate of patients with T-cell lymphoma who do have long disease control with combination chemotherapy. So further refining chemotherapy based on strategies, who benefits? So we have looked in the past at other predictors to sort of see who benefits from these sort of maximal chemotherapy strategies. And this is data on 99 consecutive patients from our center with the 3 most common subtypes of T-cell lymphoma. And you see the treatments there. When we've looked at interim PET, and in our hands, this is predictive, we see better event-free survival in patients who are interim PET negative, and really all the long-term benefit in those who go on to consolidation with high-dose therapy and autologous transplant seems to be in those who are PET negative. And that holds sort of regardless of pretreatment risk factors. So further refining these strategies, again, we sort of subscribe, at least right now, to this maximalist chemotherapy approach in PTCL, combination chemotherapy followed by transplant. It looks like in our hands and in the Nordic group that if we do a dose-intensified approach and consolidate, about 45% of patients are progression-free at 5 years. And we believe that the benefit is really in those who demonstrate chemosensitive disease. And for us, that's a negative interim PET. There are some questions about mutational profiling. Can we better risk stratify? And there's some early data sets to suggest that some of the markers listed there may predict for who's more or less likely to benefit from these approaches. Again, our goal would be to identify those who are likely cured with these standard approaches, treat them with those approaches so they're cured, but early identify those who are unlikely to benefit from those approaches so we can look at alternate or novel strategies. So other targeted approaches. As you know, there's been a lot of look at profiling, again, in people with T-cell lymphoma. And one of the best characterized, again, is an angioimmunoblastic T-cell lymphoma or follicular helper T-cell lymphoma, where we know that those tumors are greatly enriched for mutations in epigenetic modifiers like TET2, DNM, T3A, et cetera. And we did a retrospective look led by Paul Ghioni, who was a fellow with us, who's now at Roswell Park. And it looked like, at least retrospectively, that patients with follicular helper T-cell lymphoma had higher rates of response to HDAC inhibitors, both overall and complete responses, either single agent or in combination. And we think that goes along a little bit with our understanding of the biology, not as necessarily hitting a target, but an association between those genomic abnormalities and response to these drugs. Similarly, there's been some data sets, this one from France, looking at patients treated with a demethylating agent, in this case 5-azacitidine, again showing that those with angioimmunoblastic T-cell lymphoma, which goes along with these mutations in TET2, DNM, T3A, had a higher rate or more likely response than those with peripheral T-cell lymphoma unspecified. The romidepsin plus TOP study that was reported this year was designed really before this was well understood, but very much like Echelon-2, this was a study that looked at adding romidepsin, so that's a histone deacetylase inhibitor, to standard CHOP. This was in a randomized fashion and looking at results. When we think about comparing this to the Echelon-2 study, the patients were a bit older. The study did not allow consolidation with transplant. And here's the histologies that were included. So about half the patients had angioimmunoblastic T-cell lymphoma, the subtype that we now think might be most likely to benefit from this approach. And this was a negative study. These are the results in terms of response. So there was really similar response for those on RO-CHOP versus those on CHOP. And you see here that the rates of response and complete response are quite a bit lower than was seen in the Echelon-2 study. Here's the curves for progression-free survival. So there's really no statistical difference there and really no difference in terms of overall survival. However, some clues maybe can learn from this study that we could take forward. One is romidepsin did add toxicity, and there were higher rates of dose reduction and dose interruption and lack of completing therapy for those on the RO-CHOP arm compared to those on CHOP. And when we look at the forest plots, we see here that while the confidence intervals cross 1, you do have this intriguing area for angioimmunoblastic T-cell lymphoma, where it looks like maybe there's a clue there that we are benefiting those patients. Again, this is not statistically conclusive, but one could imagine or hope that if we did a bigger study with those subtypes, perhaps if we did it with a drug that didn't increase toxicity, might we be able to show some benefit there. Other studies along the same line, Giro-1, a colleague of ours from Cornell, has initiated a small study looking at CC486, which is an oral histone deacetylase inhibitor, oral hypomethylating agent, an oral form of azacitidine, in combination with CHOP based on some of their data in restoring chemosensitivity in those with diffuse large cell lymphoma. And she led this small study of just over 20 patients, the majority of whom had angioimmunoblastic or follicular helper T-cell lymphoma subtype. And again, this is a pilot study, but the preliminary data is quite good, with the overall response rate at the end of treatment of the overall complete response rate of 75% and 88% complete response in those with the follicular helper subtype of T-cell lymphoma. And these are sort of the preliminary progression-free survival curves. So more follow-up is going on, but this is a strategy that is worth taking forward to look at in a larger study. So really to conclude, in the management of frontline peripheral T-cell lymphoma, I think overall does remain heterogeneous. It's only getting more so, and the prognosis is still worse than what we would like. However, there are cures for some patients with combination chemotherapy. We increase those for those with CD30 positive disease by adding brentuximab vedotin, possibly with the addition of high-dose therapy and autologous stem cell transplant. And again, I showed you the data for CHOP etoposide, and CHOP etoposide followed by auto transplant, where we think a proportion of patients would be cured with those strategies. Prognostic factors can impact decision-making. These are pre-treatment subtypes such as anaplastic large cell lymphoma, maybe mutational profiling. I'd say right now there's clues in terms of things like mutations in epigenetic modifiers, but some of those are being built into clinical trials to look forward. And I showed you our data with interim treatment response, as at least in our hands, the patients with interim PET negativity are the ones who seem most likely to benefit from these maximal chemotherapy approaches or consolidation. There's a number of ongoing attempts to incorporate combinations into upfront therapy or curative therapy, really by adding active agents, again, trying to enrich the population for those most likely to benefit. And I think more and more we're moving towards subtype-specific strategies. I think historically those have been disease subtypes, but maybe going forward, some of those will be molecular subtypes or other target subtype-specific approaches. So I thank you again for your time and attention, and I think there'll be opportunity for questions after the talk. Thank you.